So if we're reviewing the literature with topical opioids, like many things that are kind of outside the box, a lot of it is not standardized. And really a needed call to standardize the process, standardize the wound assessment. But what we do know with topical opioids is that they are effective. They are effective in reducing pain, and they are minimally absorbed systemically. So they do have, a high benefit with a low risk ratio.
In our clinical practice, we've seen a significant reduction in systemic opiate exposure. Once we start someone on a topical opiate, specifically morphine, we've been able to reduce their systemic opiate for the treatment of pain with some great success.
For pain conditions that I believe that they are applicable are for wounds that are malignant. There's definitely wounds that have active inflammation that are going on, and wounds that the literature kind of supports a permeable type membrane. The wounds that have not been, that are not so successful are usually when they don't have that granulation tissue, opioid receptors. So usually in your acute inflammatory type of response, they have shown some benefit.
I would say predominantly the wounds that we're treating are the malignant, fungating type of wounds, chronically open wounds. From a safety perspective, there's still very limited data that's published on topical opiates. There was a nice review of about 27 articles, but it only included 170 patients. And so the information that we have in terms of appropriate dosing or dose titration is still very limited and I think preliminary. But in terms of safety, we understand that we're going to consider the same contraindications and adverse effects that you would get with systemic opiates, but predominantly they're going to be less severe, with most of the hydrophilic opiates not penetrating the wound, and so you get very little systemic absorption, and that's been shown in various publications. However, your more lipophilic molecules like fentanyl or methadone, you do have to worry about a significant amount of systemic absorption that could potentially occur, especially with the larger size of wounds that you're treating.
One other thing I'd add to safety is usually this is second or third line when the traditional management and treatment have failed, that when these patients in cases that we've had where they've been on hundreds and even thousands of milligrams of oral morphine equivalent systemically and able to reduce them down to a couple of Percocet, I think the risk-benefit ratio kind of speaks for itself when you're able to reduce that much amount of systemic opioid, and it's been pretty miraculous for our patients because of it.
I think it's a bit of a challenge right now in incorporating this into your armamentarium of agents, predominantly because there's no commercially available topical opiate that we can use in patient care. And so we're relegated to using compounding pharmacies or your local pharmacy to make these agents. I think in a hospital setting, it's a little bit easier. You have an inpatient pharmacy that can provide some of these services. But in the outpatient or in a long-term care facility, they're going to have to outsource this with a specialty pharmacy. And that's been, I think, a large challenge in our patient population once they transfer out of the hospital into either a long-term care facility, a nursing home, or when they go home.
I just echo the same things. As, when you're doing something so novel, something very outside the box, the regulatory type of things that go into place really need to be thought out. Now, if you're dealing with a population that is terminal, you maybe have less limitations, like in a hospice setting. That there is the poor man's version of it, where you can take a tablet of, say, Dilaudid hydromorphone and crush it up and put it into a hydrophilic type base, like a KY gel, kind of a slurry type. So there is the poor man's version that you can, but looking at expanding it towards a hospital system, it does pose a lot more challenges, like Levi was saying, for sure.
I would see this treatment evolving in the future, hopefully commercialization of a product that could be available. I think that would make access to this medication treatment a lot easier. And then having some standardized, with more studies and more literature published, I think we can identify a standard of practice for using topical opiates so that you can roll this out to a larger audience and be able to have a beneficial effect at reducing systemic opiate exposure and really improving safety of patient care.
Future populations, really, in thinking about nursing homes, and you think about our baby boomers that are all aging, and that whole next generation of wounds and debility and morbidity that is going to exponentially grow. And I think having a product like this can be very beneficial. And you think about what some of the biggest things in nursing homes and long-term care facilities that they're always dealing with is wound care. And I think the traditional type wound care agents that we have now are questionable. I think the data there is very questionable on how they are applying. And I think this is a unique opportunity to really become a solution to a pretty horrific problem when you're debilitated and sick. But you've got, once the systemic traditional things are not working to relieve that pain, and taking that solution directly right to the point of insult, I think it is going to be a real big game changer.